Dr. Liliana Oakes, and you can see from the board that she's an assistant professor of geriatric medicine in the Department of Family and Community Medicine, and she also was a geriatric fellow with us. And I have to tell you that she's one of the best we've ever had, and it's been totally delightful. She has a lot to share with you this morning, and you're really going to enjoy this. Thanks.
Thank you, Michelle. Well, good morning, everyone. I'm so glad I rarely get the 8 a.m. talk, right? I usually get the one at 4 p.m. So I'm just counting that all of you are fresh and you got all of these exciting talks yesterday. So we're going to be talking. This is a talk that you do, and I just guide you to get some new concepts and make you understand this beautiful area, which is how we are dealing with older adults, and they have very special needs, and that requires that we get people interested in this field and apply the concepts appropriately for their age. So you read the title and you came this morning thinking, hey, we're going to learn about this geriatric assessment. And I bet that while you were driving, you were thinking about geriatric assessment. And I would like to hear, when you hear this word, geriatric assessment, what kind of things come to your mind?
Reviewing their health history.
I'm sorry?
Reviewing their health history.
Very good. So you review all the past medical history, what's going on. These people come and they have 70, 80, 90, 100 year mental, and physical history. So very good. So you do your medical portion. What else we will do in geriatric assessment?
I want to know how well their mind still works, if they're still competent and active. Maybe active, how active are they?
Okay, very good. So two different things that I wanted to point out. So you mentioned, I wanted to know how their brain is working, how their mind is active, and you mentioned the activity level, the physical. So another two components, all the past medical history, diseases, very medical. Here somebody said, well, I'm interested to know they still functioning well in their mind and they are still active. Very good. What else will you do in geriatric assessment? Somebody?
Feeling.
How they're feeling. Can you tell us what to do?
Positive, if they're down, and that kind of tells you kind of where if they're telling you they don't feel well, they're probably not doing very well, or it could just be psychological.
Wonderful. So we're addressing the physical, we're addressing the mind, now we're addressing the soul, their emotions, their feelings. Are they depressed? Are they functioning in the family appropriately? What is keeping them probably from functioning appropriately? Great ideas. What else? Anybody interested in families, or do you think it's important to talk about that in the geriatric assessment? So like what kind of things?
Well, like if they're living alone, if they've got, any caregivers, if they've got children that they reside with. Basically, with the assessment, you're actually you're assessing, but then you're going to be coming up with a treatment plan for that patient.
Exactly, we will talk about a little bit later on. That's the other aspect. They don't come as individuals with diseases. They're human beings, placed in their families, placed in their communities, placed in their countries and the world. What is that need and the network that this patient is having is vital part of the geriatric assessment. If we don't know that environment and what is going on with them in terms of their families, we can fail in treatment. So those things that are great that you just mentioned, guys, is what we're going to be spending in the next 45 minutes. We're going to be talking about what are the basic components of the geriatric assessment, and some of you already mentioned what we're going to be talking about. We're going to talk about functional status. In geriatrics, we focus not in cure, we focus in care. And the care in geriatrics is very related to where they are in their lives at that point, what are their goals, and how we can preserve their goals for the patient and the families. We're also going to recognize the importance of the geriatric assessment, and one of the most beautiful things in these kind of conferences is the importance of many other disciplines taking care of the same elder and their family. So it's very important that it's not the physician leading this work. It's a team approach that we try to have in our offices, in our hospitals, wherever we are, to try to offer the best geriatric care for the patients. So the first thing is, some of you gave some idea of what the geriatric assessment, we will review in the definition, and I'm going to tell you a story. Every time that you review history and you remember why we start doing geriatric assessment, I think it makes a big difference, and then we will be reviewing other things. This bypass one, let's see what's happening here. Okay. In 1930s, we basically have Dr. Marjorie Warren. This female was working in England, and in those days, everyone that got sick didn't function very well because they have a mind problem or they were too depressed or became a burden in their families, were put in infirmaries. Everybody got a bed, you have usually nuns, and they were taking care of all of these people that were isolated from their communities. Dr. Marjorie Warren came and said, many of these people are elderly, why we don't systematically start reviewing what are specifically the problems that they have, and start doing interventions. And she was the first one that developed what we call these days geriatric assessment. She started applying different tests, instruments, and a way to see these patients, and many of them actually were able to get rehabilitation, got into their feet, and move back to their communities. After this was done, many people start developing, well, we maybe are neglecting the care of people and we're just stereotyping them as being bedridden, homebound, and we're just trying as society to try to remove them. We're moving far away from that model. We're trying to incorporate people and keep them as much as we can in the community. It's cheaper for the system that have hospitals to do that. So I think it's worth it that we know about that. So what is exactly geriatric assessment? Geriatric assessment is a multidimensional, and all of you mentioned different areas. That's what multidimensional means. We have different areas in understanding how these elders function. It's often interdisciplinary, and what I mean by that specifically is if the physician addresses, like you were mentioned there, we're going to have a treatment plan. We wanted to work as a team and have different eyes that can tackle the problem. So we have usually a team where our nurses are vital. They get geriatric training, and when they vitalize the patient, they already are addressing other issues such as elders that come with dizziness immediately get orthostatics, and they wait 2 minutes when they stand them up, because in geriatric patients, they will probably be orthostatics a little bit later than if you have a young adult. Then we will have a thing where if the patient has a lot of psychosocial issues, is isolated, poverty, neglect, we maybe work with a social worker, and the social worker will play a vital role in following all of those issues that are vital to the treatment of the elder. If the patient is falling, we found that has major atrophy in the legs, is weak, we work with our therapists, and we start doing a whole address of the needs, and we can send them to home, we can bring them to a facility, we can rehab them. If we have a psychiatric issue that the geriatrician maybe has some limitation in the training, we work with our geropsychiatrist. And then we will manage the care as a team if the patient has cardiovascular problems and needs a cardiologist, or needs a neurologist, or another specialty where we see not the disease but the whole context. So that's what interdisciplinary means. And it's a diagnostic process intended to determine in every elders all the medical, psychosocial, and functional capabilities and problems, with the objective of what? At the end of applying all of these tests, we wanted to have an overall plan for the treatment and what is going to happen in the future. And what I mean by that is, it's a process that is dynamic. It's a process where we hear the families too, we hear the patient's agenda, and we also explain to them where we are. Sometimes we come with one agenda, a family member comes with another, and the patients come with another. So our role is to facilitate in this geriatric assessment where we are as a family members, as a patient, as a physician, as a team, and trying to establish what are the goals of care. So it's pretty complex, right? It's not straightforward. They come with bronchitis and you give an antibiotic. I mean, we're talking about a bigger picture in geriatric assessment. So there are two types. You already are kind of grasping the idea that these are not things that you can do in 10 minutes. Geriatric assessments are long, and they usually are applied in our offices if you are a new patient or you bring a new family member to us. we will usually apply the brief, and I will go in detail of what is that. But over time, we will apply all the entire geriatric assessment. So you basically can split it. If the patient is very complex, we maybe deal with the medical, but at some point we're going to add the instruments to measure and have the treatment plan appropriate to their needs. So what a brief geriatric assessment is, your history of present illness. All of you are familiar with that? Or I need to go over a 30-second explanation. History of present illness, everybody comfortable? Don't be shy, we need to explain it, I will go. Everybody knows that, good. So you will go over all the medical portions, right? Then you will go in functionality, activities of daily living, instrumental activities of daily living. What is that patient functioning at home, and is that patient functioning in the community and being independent? And I'm going to spend time in those today. We're going to address the mind, the brain, meaning mental status examination. You will have a whole lecture about cognition with Dr. Horton. We will just go over some of the, how we do it a little bit today. And how they are feeling. We do geriatric depression scale. So in a brief, if the patient comes, usually we're able to do all of those in the first visit. We're talking about 1 hour visit with the patient, sometimes 2 hours depending on the complexity. And the multidimensional is everything that is in the brief, but we're also focusing on full risk assessment, advanced directive inquiry. We're looking into hearing and vision screening, the social work assessment, and the health maintenance intervention that is very easy to do every visit to address where we are in terms of prevention, if that is the appropriate thing to do, right? It's depending on the life expectancy and other discussions with families, but it's vital that we keep it in mind. Okay, there is a concept called frailty, and geriatric assessments also are targeting patients that are frail. What is frailty? What do you think, what kind of pictures come when you hear the word, oh, somebody is frail, or I have a patient that is going through frailty?
Physically weak.
So weakness, maybe these patients are weaker than others, very good. What else? You can break them easily.
But they would just break.
Yeah, so they look like you really need to be careful when you approach them, right? So yeah, there is something about the look of them that you're like, this person's kind of sick, and you have seen them at the hospital, you have seen them in the community. It's the elder that you get into. I always get into the airplanes when I go to conferences, and I look around, right? And I make all those big diagnoses of who is in the frailty category because I maybe get called, right? So that's the kind of people that you look and say, something is kind of funny about that person. They don't look that good. Good. What else? Usually older, right? I mean, they are not, 65-year-old, right? These are people that tend to be old, and we will talk about how old. Anything else?
Vulnerable?
I'm sorry?
Vulnerable
Vulnerable. What do you mean by that?
to illness, to stress, to...
Also in all the areas, right? The physical one, and also you maybe say this is a person that maybe generates anxiety in the caregivers and they neglect them because they are so sick. They are vulnerable. You know that this is the patient that comes to your visit and you're like, if we don't do a lot of prevention and assessment, this person is going to get sicker. So all of those things are exactly frailty. So usually they are older than 75 usually. They usually come with a problem list of 20, right? Diabetes, hypertension, coronary artery disease, status post-Cavage, peripheral vascular disease, isolation, poverty, that's the kind of patient that is frail, right? Has significant psychosocial problems. They are maybe neglected, they are profoundly depressed, they maybe have I have a 74-year-old that was schizophrenic all her life, and then she developed acute urinary tract infection. She developed a hernia called a Morgagni hernia. She ended up at the hospital with an abscess. I mean, a lot of things going on mentally and physically. They are usually isolated and impoverished, right? I mean, the healthcare for these people is so expensive. With Medicare Part B, we will have some coverage for medications, but this is the people that need to choose, okay, I eat this week or I buy my medications. I mean, it's a very tough choices. And they are probably the last one. They're a family of one. They already buried everybody else, and they're just living by themselves because they don't have any relatives, or they never married, or they are widows. And they are at high risk for adverse health outcomes. So this is the people that the Geri assessment helps because we can tell families about prognosis, what to do, how to work with them, because we know a minor thing are going to put them back to a very bad weakness situation, and they're not going to be able to be back where they need to be. They're high risk for illnesses and hospitalization, and of course, this is the elderly that is frail, got a pneumonia, was in the ventilator, got out of the ventilator, and then they are not moving, they're incontinent, they are in delirium, and they are already leaving the hospitalization, and then the family said, I cannot take care of them, so what is the option? Institutionalize them. And the problem is the government doesn't pay for institutionalization. This is self-paced for. This is a big teaching portion in the lecture. Many people don't know. We assume that you get older and if you get sick, you will go and choose a cool nursing home where everybody plays being going. That's not exactly the reality. That's a self-paced. So families go between $1,500 to $4,000 a month. And if you are really poor, you get a Medicaid bed. And the reality in San Antonio, like many places, is Medicaid beds sometimes are not in the best facilities. So we need to understand that in people like you, because there is that misconception of what is going to happen when you get old. And it's good to think about that in a culture where people think about that. In other cultures, institutionalization is not an issue. You know, I was raised by my grandparents and my mom. We lived with them until he died from dementia. My grandma died from a cerebrovascular accident. I took care of them. I'm taking care of my mom right now. And I don't know, I will talk to my American Colombian daughter and see if she will take care of me. I don't know. I haven't been, and she's 18 months, so we will see. But in my culture, you don't institutionalize people. Here you do, so you need to be culturally sensitive. Many of our Latino families said, I will take care of mom at home until she died. I promise her she won't go to a nursing home. Right? And so we deal with those issues, and that's part of the geriatric assessment, where families are, and they get offended if you don't know where they are. Functional status is the other component where we focus a lot in the Geri assessment. So functional status is the ability of the individuals to live fully, mentally, physically, and socially in their activities of the daily life. So functional status, when we do the Geri assessment, is, are they able to do all the things that they do physically? Are they able to function mentally? Are they able to integrate in the community and continue participating? If those things are the answers, no, 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 we need to find out why. And the Geri assessment is intended to see where they are in that point of life with their families and help them to plug as much as we can in what they think is their quality of life and their goals of care. We usually do the functional status in the review system. So you have your H&P, and when you go to the review system, you apply the scales and you ask the caregiver or the patient, are you doing these and these and these and these? And I said you need to, in geriatric, usually have a third party confirming your information. Your beautiful demented people will fool you completely. They will tell you that they have been traveling, they continue driving, there is no problem paying finances, life is great. You talk to the daughter and they quit driving 2 years ago, mama is getting lost. So, you know, a good Alzheimer's patient can fool you. The story that I relate to you is I was an intern, I came in training, I went to Morningside and I spent 1 hour talking with this delightful 85-year-old female that told me this great story, went to the mall and all the shopping that she did. And we were talking about the daughter and I was like, man, cool, you know, she's in the nursing home, but she goes shopping every weekend and wait, this is great, you know. And I went in and talked to the nurse and said, I need to talk to the daughter. I just wanted to let them know that I'm the new intern, the new resident here. And can I talk to her? And the answer was, oh, she hasn't been here for almost 6 months. We don't know where she is. And I came back. I couldn't, you know, I didn't know much about dementia and all of these things. And I came back and talked to her, and she looked at me and said, who are you? And just to tell you how these kind of situations you're going to encounter them. So whatever your specialty is, for example, if you're a therapist and you're pretending that a patient will carry out your instructions. So from now, today to tomorrow, you're going to do these exercises. Well, you need to understand where this patient is coming from. So reading the history is vital. This is a demented patient, very advanced. Maybe my recommendations about home exercises or homework won't work very well. So that's very important that we check all of those things on them. To understand functional status, I think the best way is also think about us. Otherwise, it's kind of hard. I will ask that you raise your hand if any of the follow happen in your life. Have any of you ever broke a leg? Okay, we have one over there. Look pretty good a little bit. Have any of you broken arm? Well, this is a healthy group. Usually people raise their hands a lot. Anybody wearing glasses or contact lenses? Oh yeah, half of the all. Okay. Have anybody broke any other part of the body? We have sometimes neck. Okay, what part of the body?
I broke my collarbone.
Your collarbone?
I broke my toe.
Your what?
My toe.
Your toe. Wow, that's painful. Anybody else broke anything else? Okay, anyone? Okay, what did you?
An ankle.
Your ankle. Okay, we're going to come back to you too. Who forgot the contact lenses this morning or the glasses? You did. Tell me, are you enjoying the lecture?
I can actually see it this big.
Oh, you can see it. Okay. But otherwise, if it will be smaller, what's going on?
I would just listen.
Did you drive safely this morning?
Well, yeah. I mean, it's just focusing on it for long periods. It's hard.
Okay.
But yeah.
But what happened
Yeah.
in the
Okay,
worst case
it was
scenario?
empty.
What happened?
Huh?
In the worst case scenario, what happened when you don't wear your contact lenses?
I can see. I just signs. I just don't see like turns, like if you give me directions.
And you feel uncomfortable sometimes? Okay.
I say I'm living in fuzzy world.
Yeah.
When
And a fuzzy world.
I call it I'm in fuzzy world.
And a fuzzy world. Well, that's a great description. Thank you. And I wanted, what is your name?
Not rather local.
Magda? Magda, tell us about your story with your broken leg. What happened, if you don't mind?
Oh, it's been continuous. I've broken once and then re-injured and it's the same leg and ankle.
Okay, and
But,
it was an accident?
Yeah, the first injury, I was bedridden for 2 months.
Okay, how old were you? I'm sorry, if I can ask your age, how old were you when you broke it?
Probably like 30.
Okay, fairly young, and you broke it and you were bedridden for 2 months. Tell us about that experience.
Very frustrating because you had to depend on everybody else to help you. And the very simplest thing that you want to do, you can't do.
Who was helping you?
My mother, my boyfriend, my friends.
Wow,
I was
you
very
were lucky. You have a lot of people helping you. What was the most difficult thing for you? From all the limitations, what was the hardest?
I think one was your personal things that you need to do. That
Be more specific, don't worry. We won't tell anyone.
I'm the teacher, I don't know.
Oh, okay. Yeah, that's a piece of information that maybe, yeah, they can use that against you. But yeah. So toileting, maybe.
Toileting, yeah, absolutely, which is very private to familial, and you were having to have help for that.
Did you have a cast in your leg?
Yes.
So what bathing was, you probably, like the plastic here and
Stick
trying
the leg
to.
up, oh, yeah.
Wow, that's intense. Thank you, Magda. You broke your ankle. Tell us about it. How old were you? How that happened?
I was 26 in a car accident, and I have plate and 7 pins in my left ankle. And yeah, all of my independence was lost. I lived alone, 2nd floor apartment. I had to move in with my mother, which was terrible. And you know, when you're so independent, you know, that's all gone. So I ended up going back home just because I had animals, I had cats at the time. But cleaning was terrible. I think the only time I felt I wasn't in cast was when I was driving, because I was in the cast was on my left leg. So just the cleaning was terrible. I'd have to literally use my bottom to go up and down the steps each day for work. But because I chose not to live with my mother, you know, for 2 months.
So you lived with her 2 months, and then you said.
Oh no, a week.
A week. Oh, I see. So that was a week, and you prefer to use your mouth as
I chose to suffer going up
I
and
bet.
down the steps with my bottom and you know, trying to clean. You know, it was hard, especially because my cast was so heavy, very heavy. Felt like it was 20 pounds at least.
These days the casts are lighter, but We will talk about your case. Just portrays so many things. I maybe come back to you. Well, thank you so much for sharing your personal stories. I want that for a second. You imagine Magda and Lisa, right?
Yes.
And imagine that these kind of things happen when you are 70, the same things that they just shared with us. Even your fussy world, when you are 80, when you are 90. And things get bigger in proportion. We're talking about 26-year-old, 36, and look at how hard it was to make decisions of independence, lose your independence temporarily, try to do toileting and personal hygiene. And imagine then when they have been your parent or your grandparent and now they are depending on you. So I want that you portray that because that's what is one of the major issues when we talk about geriatric assessment. They come with these kind of feelings. Just exactly what you went through, but even worse because they're age. Yes, Mike.
I've also done the other side because I'm my parents' caregiver, and my dad passed away recently, and it was really hard. I had been doing these type of things for my mom, but when I had to start doing them for my dad, it was very challenging for him. You know, it was hard for me because now I had to take care of my dad's toiletry.
Exactly.
And it was very hard for him, you know. You still, of course, is
Sure.
but
Or imagine I have a lady and now she got 3 male sons. They're Hispanic. One of the major issues is we can do everything for mom, but who is going to go and pull down the underwear to help her to toilet? Who is going to help her to bathe? So I hear you, it's the opposite with males. You know, I'm the strong dad and now you're going to come and see me naked. I mean, this is the kind of stuff that we talk about in our Geri assessment. And not the superficial thing is where we are, what are your needs, let us see how we can really help you and put all the resources that we can. Now, sometimes we cannot do much in terms of offering her help outside, but we talk about it. And talking about it and acknowledging that it's okay to get some help when you get old is not that bad. And coming from a physician perspective, sometimes that helps. Just addressing the fears with the caregiver, the limitations, the shame that comes with this switching role. So that's what all of these pieces are in the Geri assessment. So we're going to go ahead and start spending a little bit of time in each one of these. And again, the brief geriatric assessment will talk about 3 major things. A personal dimension, which is how the person attends to personal needs. So we talk about, do you bathe yourself? Are you eating well? Are you dressing? All of those issues. The domestic is, okay, I already taken care of my personal stuff, but you know, Lisa was mentioning, can you clean your house? Can you do the laundry, right? Can you do all the cooking in your environment? And the last one in the outer circle is the social dimension. Do you still going outside and have a margarita with your friends? Do you still playing bingo out? Do you play dominoes? Do you go out and go shopping with your friends at the mall? Do you go and visit your children out of town and can you drive? It's that dimension that will help you to relate with the outside and the community. So when people start developing these scales, well, they will say, well, this is the cool stuff. We need to measure it. How we measure it. And then Katz in group developed these scales called activities of daily living and instrumentalities of daily living. And they say, well, we need to talk and have a common language. So we need to develop something that if somebody does it in Germany or in Colombia or in Canada, and we're talking about functional status, we are talking about the same thing. So these scales were created thinking about a common language. And these scales are used by clinicians to detect whether the patient has problem performing activities in those 3 dimensions that I just reviewed with you. And those activities are vital because if you don't do those, you are not able to survive. If you cannot pay your rent, you're going to get evicted. If you cannot buy food, you're going to starve. So we're talking about vital stuff that we take for granted. I will get up and make the coffee and eat. We know that we run out of milk or the cat needs food and we go and buy it. But we're talking about that this is what many of elders are not doing anymore. So if they live by themselves and they are becoming demented and they fall down, who's going to buy food for them? How they're going to get around? So we need to understand that these scales are vital. And I already told you all the stuff. Live independently, good functionality. They are also very good in terms of economics, in health economics and in health management. If you know that a population that you are measuring has a lot of problems with ADLs and IDLs, you know that these communities are very expensive, right? So they are indicators of if you need to invest a lot of money in people that are already needing caregivers, right? You were very expensive, Magda, when you have 5 people taking care of you. If I will pay 5 of them to take care of you, I will be broke, right? So you need to pay somebody, you need to have a babysitter, you need to have a provider, you need to bring home health and all that stuff. Medicare pays. Who pays for Medicare? All of us do. All of us are going to get older. Who's going to pay for us? The pyramid of demographics is going to be this way and not this way. And those are serious issues of what are we using resources and very sick elders these days, and what is going to happen with us? Is going to be able Medicare to pay? Go to the intensive care unit when you have an elder that is dying and we're investing $10,000 a day in their care. I'm not talking about it's right or wrong. I'm talking about we need to start talking with generations like us. What are we going to use or resources? Because all of these people that are very sick need care. That's part of geriatric assessment. Where do we use this statin that is $150, or do I really need it and better do diet and exercise and maybe say $150? That's the economics of the Geri assessment. You know, can you eat the food if I put you in the most expensive antiarrhythmic if you have problems with the heart? So those are the concepts that also are part of the Geri assessment. So usually they will ask for your personal dimension: eating, bathing, toileting, dressing, transferring, incontinence. The most sensitive one is when we address continence and elders, because the same issue. You know, it's not fun to say, are you peeing in your pants? And so we prepare them. I'm going to ask you several questions that are very important for me to know how you are doing, and all the questions are intended to help you. And then we will address the eating, the toileting, and then we said, have you had any problems with accidents? The grand majority of our elders don't come spontaneously and say, I'm here because I'm peeing in my pants. They think it's normal to be incontinent. They think you are old, well, everybody pee in their pants, so it's normal to wear undergarments. And part of the Geri assessment and the ADLs is make that as we can talk about that, and actually that's more normal. We know that when elders are incontinent, they are higher risk for falls. Why? If there are some elders that don't want to wear pads, if you wet your pants and wet your floor and you have a slippery marble floor, you're going to fail. So we need to ask that question, and that's one of the differences in geriatrics. We ask about continence, we ask about falls. We don't do that very often with young populations. So those are all a couple of pearls of what we do in the Geri assessment through these scales, are addressing those kind of uncomfortable questions that people don't talk openly. So the important thing is not only that you ask, do you eat or you bathe, but what is the degree of the activity? What I mean by that is, if you are bathing, do you do it by yourself? You get into the shower, you know how to do all the process, then you know, dry yourself. Or you maybe have rheumatoid arthritis or a stroke and you can be sitting in a chair in the bathtub, but then you need some help with the back and the feet because it's hard to reach them, right? Some people can do everything but not their back or their feet, right? Depending on their diseases. Or you are post-stroke, totally in a hemiplegia, and you need assistance completely. So that's the kind of level, and each one of the items in the scales, you're going to ask those. And I won't show anymore because you know you can find the scales anywhere, and probably you already have it in your materials. The instrumental activities of daily living addresses the domestic and the social dimension that we review, right? So they usually include the heavier housework. So do you do the laundry? The same. Do you do all the laundry? Do you only do the small items, or you don't do any laundry anymore, right? Housekeeping, do you clean your house? You need somebody to just help you, or you are not doing it at all? Going to errands and transportation, is it something that you need to ask? Not everybody drives in this country. If you were raised in other countries, you are a female, you usually don't drive. If you come from other countries, I said there are majority, there are people that actually do it. But you need to know. But if you know how to take the bus, can you do it independently, or you always need to have somebody, or Via Trans is coming right now, or you don't travel at all? And the cooking and the laundry usually are also gender related. How many of you have dads that cook all the time at home? Right? Nobody raised their hands. How many of you have moms that cook a lot when you were growing up? Everyone, right? So you need to know, it's not just, oh, you don't cook if you're a male. It's like, okay, why you didn't cook? Well, I was working, or, but now they're a widower. Can you cook simple things or warm up things in the microwave? Oh yeah, those, right? I can make eggs and boil the water and do instant soup. So we relate basically in the appropriate cultural element of the patients. Food preparation, the levels, again. Medications, the same way. Can you take it by yourself? Somebody else help you? Only a small medication. Finances, big issue. Are you paying your bills? Are you getting some help with someone? The level of that. This is a quick slide to show you that usually the first thing that you learn in life is feeding. Right? That's the last thing that you lose when you get old. The last thing that you usually do is your bladder control. That's one of the first things that you lose. They just get reversed and the other. So you have an elder that is telling you is having some incontinence, having difficulty bathing, red flags. Something is going on, right? And we have a nursing home the patients that you need to move the chin to help them to swallow because they will chew forever. They forgot how to swallow. Those are terminal Alzheimer's patients in the nursing home. So it's important that we know how the brain works because it's fascinating, they go back. We're not going to spend a lot of time on these, but basically the cognition is going to be explored by Dr. Horton. We wanted to check where they are and we apply several tests and combine them. Each test has its limitations. Some of them are related with education, so your mini mental status examination. Anybody related, somebody here that doesn't know what a mini mental is? Okay, it's a scale that was developed by Folstein in 1975. It has 12 areas that measure cognition, usually orientation, registration, attention calculation, praxis, and visuospatial activities. So it's measuring a lot of things. The majority of those functions are in the left brain and are related with education. Two of the items are reading related, so you need to know how to read, and 2 are writing related. So you need to have a level of education, otherwise you will score poorly. That's a whole other story. We're giving it actually in Rio de Janeiro in 2 weeks a big talk about culture and instruments, and we try to adjust them to our cultures and the language and everything. But basically that's one of the tests that we apply in our offices. And we always ask, what is your preferred language? What is your level of education? And Dr. Horton is going to do the clocks and everything. She's going to spend time with that. The geriatric depression scale usually, as it says, is bilingual. We have a standardized. It's a screening test. It goes over 15 questions. The original is 30. We use the 15 version. And if you score 7 or above, you maybe have probably depression, and we explore that. The multidimensional is everything that we just talked about, but there is a full risk assessment, which I'm going to demonstrate quickly. I need a volunteer. Can you help me? Yes, come here. When we see an elder in our office, first of all, we do not use chairs like this because they're going to fall, right? So ignore the wheels. But we do a very short test that you can actually do regardless of your specialty. It's called, it's a fancy test. I'm going to tell you your name in a second. Remember your name? Rowan. Rowan, yes, Rowan. Rowan, I need to ask you to do something, and I'm going to, your last name because Rodriguez. Oh, that's easy. Rowan Rodriguez. Okay, Ms. Rodriguez, I need to ask you to do a test for me. Please cross your arms and your chest. And then I wanted that you raise up without using your arms. Walk around 6-7 feet, turn around, and walk back normal. Put your arms down and continue walking. Very good. Very good. Thank you. Have a seat. How long it took Rowan to do that? have? Seconds, right? 10, 15 seconds. This is a test that many elders will take longer. She's young, she's strong, she's in good shape. Many of our elders, when they come, they're going to be in the chair this way. So you need to look into their posture. They maybe are very kyphotic. They maybe have rheumatoid arthritis. You need to look at. But when you ask the test, what you're asking them is to don't use their arms so you can see their strength in the lower body. By asking them to do that, you are already checking, are they weak? And some of them will do this. Some of them will do it 7 times and finally they will get up. Some of them will say, I cannot do it, I need to use my arms. And the same way when they walk, are they limping? Are they have a stroke related? Are they shuffling? Are they turning around fine? Are they smooth? Is the swing in the arms normal? And this test is a fancy test. It's called the Get Up and Go test. It doesn't take you much time, but it gives you a lot of information. So that's one of the things that we do more sophisticated in our office with something called Tinetti balance scales. But just asking an elder to do that gives us tons of information. Their posture, are they leaning toward, are they have a wide gaze? I mean, all of those things are vital and it takes you 30 seconds. So that's part of what we do in the full risk assessment and the balance and everything. The advanced directive inquiry, we try to give it every visit depending on the complexity of the patient and where they are. Remember, advanced directives are a white, a Caucasian paradigm. If you go to other cultures, you don't talk about that. You don't talk about what you want when you die because like Koreans believe if you talk about that, you actually are telling them they're going to die pretty soon. So you need to be appropriately, culturally appropriate with these issues, but we try to address it little by little and find where the elders and the family are. Hearing and vision screening, or nurses usually do that, and it's done usually in the few first visits unless the patient comes with the hearing impairment, which in that case we probably move pretty quickly into the diagnostic. Social work assessment, the health maintenance, we just talk about that, we talk about that. And this is just a quick model of services, different model of services that we have depending where they are. If you are the patient and you need this is based on an English model, so chiropody is podiatry basically, but do you need additional nourishment, helps for the person that the caregivers, welfare at home, hospital admissions. There are a lot of services that also are given in the United States, home health services, provider services, Meals on Wheels, we have nutritional centers. So we have infrastructures that facilitate the care of elders depending their needs. Big issue, if there is something cheap that we can do for our elders, vaccinate them. Millions of deaths can be prevented if you just give a pneumovax after the age of 65 to all of them, or if they are younger but they have COPD, coronary artery disease, renal disease, any disease that can make them immunocompromised, you can get the pneumonia vaccine repeated every 10 years, your tetanus vaccine, your influenza every year. And you need to do your screening. This is what I will mention to you guys. We do not offer colonoscopies if you are 85 years of age and you're very demented. Why is that? Does it make sense? That you will put a demented guy who are moving your head, you say no. Why?
Well, because what are you going to fix at 85?
At some point, I guess I was thinking that you decide whether it's in the best interest to treat them or not, to go any further with healthcare. I mean, is it going to improve their quality of life and what they have left or not?
That's the point. We do a screening if you have more than 10 years of expectancy of life. So if I find something on you, I actually can extend your expectancy of life. Plus, in a demented patient, put them under anesthesia or a sedative, and then put a tube that will cause pain, and you move them and put in an environment that they don't know. It's going to be almost like you are torturing them. So we are very careful who we're treating. And don't take me wrong, I have 85-year-old age people that are running, they do not smoke, they are into holistic medicine, and they are studying something, and if they are going to live longer, we're going to proceed with that. Their grandparents die at the age of 100, go for it. So you need to look not by the age. As you are getting you can have a 49-year-old already bedridden in pretty bad shape and a 90-year-old that is still functioning in the community. So, but the point is that we look into the life expectancy, what are our goals of care, what are we trying to do, and those are appropriate questions. Yes?
I think something too that in medicine, many times people want to know, well, what is causing it? You know, we want an answer. And I think it's real important that we realize that when we are in situations like that, we can say no to exams. Because you do feel pressure from the medical community to want an answer as to why is this happening.
Sure.
But it's just the idea of, we want to know why.
Exactly. And those instances it's a shared decision, right? Families, the other physicians. I'm going to give you one example which I think is very appropriate. There are instances where knowing doesn't mean that you will treat it, but you will help the family to make decisions. Have a lady develop breast cancer, and the surgeon says she doesn't want surgery, I'm not going to stage her. Meaning, do the bone scan, the CT chest, the CT abdomen. Well, the patient says, I wanted to know how bad it is, not because I'm going to get chemo, radio, or surgery. I wanted to know if I'm going to live a year or 6 months, or I have a chance to live longer. So we actually stage her for the purpose of a living will. And that's okay too, right? You need to ask family. I have prostate cancer, my dad has prostate cancer. I wanted that you biopsy and tell me I don't want treatment, but if I truly, truly had it, I wanted to make plans, go and enjoy my family, plan everything ahead and die. So in geriatrics, the two instances happen. Sometimes we need to say with a demented patient, you know, I think we're not going to treat it. I think this is the point where we say no more. Hospice is appropriate. But there are instances where we said, okay, we're looking. And I called the surgeon and said, this lady is not going to get treatment. She wanted to know prognosis. And I think it's a reasonable discussion. So it's a little more complex, and thank you for the comment. I mean, things are not black and white.
I think a lot of the problems that I face, I think with the demented, I work with Alzheimer's and dementia residents, patients, that families are not educated, and so they're making decisions, and you see them all the time. You know, you have this 90-year-old person, and they want to take them through the surgery, and they want to do this and do that, and I think it's just a lack of education on the part of the families. I think we just need to somehow do a better way, do better with educating them and letting them understand. You're not prolonging a quality of life here, you know, and then the patient's never the same anymore if they make it through. They're never the same. They're always worse than what they went in.
And I agree. One of the things that we do, and we have the time, and Jerry, we have the time. We don't see 20 patients in half a day. We see less, but we spend a lot of time in, okay, what are our goals of care in your arrival? Every time that you put them in a surgical procedure, in anesthesia, that you change the environment, if they are too sick, what is going to happen? Families need to know, and we need to empower them. If you are not a physician, but you are treating them or dealing with them in some area in your training, and you have a suspicion that they are not very well informed, it's okay to teach them to be assertive. Go back to your doctor, write your questions, and get some answers. It's a right for our patients to do that. And we can help them by doing all of this training, and the Summer Summit is empowering you as some sort of in your area. Be sure that you can address those issues. This is something that is not right here. Go and look for a second opinion or a better care, or maybe things are not doing it the appropriate way. This is just to finish, 2 more minutes. It's a true story, one of my patients, of what we did that make a difference in the care of this patient by doing geriatric assessment, and very different to what many times happen in doctors' offices. Not to say that my colleagues don't do a good job, because some of them do an outstanding job, but you will see that the geriatric assessment definitely empowers families and patients in a different way. This was a 73-year-old female patient of mine that came with the son. They have also a provider, the daughter-in-law, so they have a lot of people involved in her care. And they were noticing that she was deteriorating and being very moody. That's the way that the family described initially in the history. Her son, Mr. G, reported that she has been in the wheelchair for 10 months after the fall. She had a minor hairline fracture in the hip, and she just stopped walking. And they just went to the doctor. She got painkillers, which was appropriate, but nobody looked into anything. Just treat the pain, go back, I will see you. And then they come to the Jerry office 10 months after. She hasn't been mobile at all since that. She got multiple episodes of forgetfulness and dementia that somebody diagnosed 2 years ago. But asking more detail, the diagnosis happens 2 years, but the memory problems and financial problems started 5 years ago, which is something that we do. It's not like, oh, your mom is demented. Like, when was the first time you noticed all the social dementia thing that she started dropping? And the process was happening longer than that. She got diabetes for 10 years, hypertension, and arthritis of the knees. She was on Aricept, but as soon as she fall, somebody says, well, we discontinue it, and then she went down the hill after they removed it. Aricept is a cholinesterase inhibitor. It's one of the medications that slow down the progression of dementia. For if you didn't know that, that's what Aricept is. The physician recommended at that point, she got delirious, she was in pain, she was old, give her an antipsychotic because she was agitated and aggressive, and she didn't tolerate it, was so sleepy that they couldn't even wake her up. So didn't tolerate antipsychotic, and they just dropped it, didn't readdress that issue. She got appropriate diabetic management, good control of their sugars, and the blood pressures were okay. She was taking an aspirin a day. When we applied the Geri assessment, we found that she was able to eat by herself, but only soft food. She was choking, and she couldn't cut the big meat, the big pieces, was unable to do that. She was already needing a lot of help in the dressing. She was totally dependent on the bathing because she was wheelchair bound. She couldn't manage in the shower. She was incontinent to urine for 1 year, and she was partially incontinent for bowel. And what we found is when she was so deconditioned in the wheelchair, she developed what we call functional incontinence. If you are so weak that you cannot go and reach the bathroom, what you do? You pee and poo in your pants, right? It's not something bad with her. And right now we were suspecting her dementia was getting worse. Maybe that was a component of it, right? Your judgment. Oh, I'm going to pee. Well, I'm going to pee here. They just forget you go to the bathroom. Her son and provider prepared the meals. She wasn't able to transfer herself, so we're looking at that she was lucky to have a son, a daughter-in-law, and a provider, but they will need it to lift her, to put her in the bed. And other instrumentals were completely dependent. So when we do in our office the instrumental activities of daily living, if all of them are already dependent, we just address the ADL, but we know if somebody is already dependent in the social dimension, they're probably not doing much in their personal dimension because they're already gone, as we call it. Okay, Miss A wasn't able to manage finances, of course, I told you that, and socialize, very few friends. Her main activity was watching TV all day long. We did a mini mental. She was a professor at the university. It was 21 out of 30. The cutoff for mild dementia is around 20. She actually, this is what I was telling you, highly educated, she can fool you. She didn't test that bad. But when we did the clocks, that Monica's going to spend time with you, and I wanted that you think about this patient when she talks to you, she wasn't able to draw a clock. Drawing a clock and the clock drawing trends require that you have a lot of the functioning of the brain working well. When you ask somebody to draw a clock, and I usually do it here, but we didn't have time, she wasn't able to do it. So she scored good in the mini mental, but her executive function, the ability to put together pieces, judgment, visual spatial thing, praxis, wasn't there. And the GDS, she wasn't depressed. So we examined her and found that she was pleasant. She was 90 pounds, very skinny, a cacactic lady. She got severe contractures in the lower extremities. She got generalized weakness with no focal deficits. She only was following simple commands. And when I tried to examine her and move her to the table, she became very agitated because the pain. I tried to examine her and stretch the legs. They were so contracture because nobody has been moving her for 10 months, right? And families were taking care of her, but you know, what family member knows that you need to move their legs? Unable to stand. And what we did is basically we combined all the evaluation. We found that she was agitated, she got advanced dementia. We were able to talk with the family. With the new agitation and everything, we wanted to rule out delirium. We found that she was very deconditioning. There are a lot of caregiver issues. And what we did is we did a lot of education. We talked to the caregiver network initiated for Alzheimer's. Physical therapy, occupational therapy got involved to decrease pain and managing those contractures. we continued at home with the family and provider because their wishes were to keep her at home. They didn't want it to place her. And we discussed the power of attorney. The demented patient, the legal issues and the medical issues needed to be resolved. And the important thing is, you have here a lot of information, is that the geriatric assessment helped the clinician and the patient and family to establish appropriate care and treatment goals. So all of these things that we discuss and participate and thank you for all the personal experience that you share, are just intended to put us in the place of these complex patients and understanding their dynamics. The geriatric assessment improves patient care because it also involves the family and involves what the family's agenda is. And our goals of therapy and intervention should have function as the primary goal. Is you were doing this before, would you like to be doing it again? And that sometimes the answer is no. I had a sweet little elderly lady at the nursing home that she didn't want to walk, and I said, why you don't want it to walk? Oh, I walked 75 years, I'm done with the walking. So for me, the agenda was putting her to walk. For her was like, hey, I'm happy, I just wanted to be in my wheelchair everywhere, and so the goals got changed. Well, any questions, guys? Anything or any comments? Anything that you wanted to share with your colleagues?
How do you deal with a patient that has been married for a long time and either the wife was a full caregiver and then now you have a husband that doesn't, as you say, can't cook, can't clean, or a lot of times what I see is a wife is has no idea about the finances. They come
Sure.
and they have no idea, and it's so overwhelming.
Sure.
Although she can keep, take care of herself, she now has no idea how to take care of any kind of business because,
Sure.
she just never had.
She didn't do it.
Two of these, and it was just very heartbreaking to watch.
I bet.
And, I'm just kind of careful what you say, but do you get people that come in that you have to kind of teach these other?
We approach it in multiple levels, but you are right. These complex cases, when you don't have, I'm assuming that this lady doesn't have any relatives. So what we usually do is involve them with a caseworker. Sometimes we need to involve APS, and we just try to do it in the minimal way where all the finances and everything legally will be in a bank, and the lady will learn to go and cash the check or use a card. And don't underestimate, many of them never have done it, but when you keep them simple routine and you are able to put all the assets in one place, many of these women under the need will do it. Now, in the worst case scenarios, we can do guardianships, which is another long legal issue, but the state can appoint guardianships for these people. But we try to don't get into that if we can. Now, there are a lot of voluntary places where people can actually, if you connect them to the social worker, will be helpful to go and help the lady and at least take her, for example, give her the right to the bank. And so we try as much as we can in the interdisciplinary model, resolve them. And some of them are really hard, guys. Some of them we try to put all the effort that we have, but sometimes we reach walls that are really hard. And people survive, with or without the help, they survive, they make it. In the worst case scenario, they go and APS will deal with that. But we try to use everything that we can. Thank you. Great question. Any other comments? I think Michelle is here. Yes,
That was excellent. Thank you.
Yeah. caterpillar